So, good morning and welcome to Healthy at Home. My name is Dr. Melanie Carminati, and today I will be chatting about pain science and more specifically the biopsychosocial model. As a disclaimer, this is purely educational. What I'm doing during this lecture is not physical therapy. It is an educational tool that we use in physical therapy, but if you are in need of one-on-one care, you can contact us at that email there or call or text that number. So the agenda for today is, first, what is pain? Then we'll talk about the biopsychosocial model, pain terminology, sensory homunculus, and neuroplasticity. So this is a big paraphrase from Lorimer Moseley, who I will be primarily referencing his work and Dr. David Butler's work as well, because they are the two primary pain scientists based out of Australia that have come up and really made popular the biopsychosocial model. They both are physiotherapists, and in their work with patients, most times, people come to physical therapy because they have some kind of pain and discomfort. And they just found over the years of their treatment, using traditional techniques and then even some advanced techniques, that some of their patients were still experiencing pain. So they wanted to figure out a way to help their patients and figure out why are these patients still in pain. So through their research in neuroscience, this paraphrase explains the whole breadth of what their work is about. Pain, I'm just going to read some of the key points. Pain depends upon the brain evaluating a massive amount of information, including danger data from the danger detection system, but also cognitive data. So that cognitive data can include expectations, previous exposure, cultural and social norms, beliefs. The context is critical, as well as other sensory data. We know now that pain can be turned on or turned up by anything at all that provides the brain with credible evidence that the body is in danger and needs protecting. Remember, it is not a pain message that is being modified, but a danger message. This is the dark side of neuroplasticity. The dark side of neuroplasticity is one of significant reason that recovery from persistent pain is seldom a quick fix, but requires a journey of patience, persistence, and good coaching. So that is from Lorimer Moseley, who is the professor of neuroscience and the chair of physiotherapy in Australia. So pain relies on context. He mentioned that in his paraphrase. The sensory information needs to be evaluated by your central nervous system. So that sensory information can be smell, touch, sound, taste, and vision, what you see. And then your brain evaluates this information, and the evaluation involves complex memory, reasoning, emotional processes, and a consideration of potential consequences of the response. So the biopsychosocial model is what their model is, and it's a model that says that when you are treating pain, you have to consider these three factors, because these three factors together create the pain experience. It is not one, it is not the other. Together they are creating that pain experience. So biological influencers of pain. Biological influencers can be visceral, say one of the organs, stomach, intestine, gallbladder. You can have, say, a laceration in the intestines, or you could have, a tumor in one of these areas, or some other kind of dysfunction. Vascular, that's our blood supply. Neurogenic, involving the nerves, and then musculoskeletal, which most of you know is bones, ligaments, joints, muscles, fascia, tendons. So all of that stuff falls into musculoskeletal. So if there's any kind of impairment, that would be categorized as biological. Psychological and sociological influencers of pain. Psychological can be stress, depression, anxiety, trauma. Sociological can be lack of support system, lack of resources in your environment, or a family history of persistent pain. An example that they gave in the book that Dr. David Butler and Lorimer Mosley put together, which is called Explain Pain. I'll have that in the references at the end of this. An example of this family history of persistent pain, sociologically and psychologically, how that can influence is they gave an example of, oh, Aunt Sally, she had back pain and she could never leave the house. She wasn't able to go to anyone's birthday parties, any of the celebrations, because that back pain kept her inside for most of her life. So that is a sociological example of how family history can influence psychological thoughts that I will get into a little bit more later. So some pain terminology that's important is nociceptors. These are the danger detectors, and they're covered. They cover our body, so everywhere. These nerve receptor endings transmit that danger information to our brain. Now, some of these other terms, such as central sensitization, allow for there to be a change in the neural map in the central nervous system, which can lead to experiences of hyperalgesia and allodynia. Hyperalgesia, listed down here, is an increased sensitivity to pain, usually causes hypersensitivity to stimulus that would not normally cause pain reaction. And then allodynia is pain response from a stimuli that does not normally provoke pain, specific to central sensitization. So an example of allodynia is someone experiencing pain when they are outside and a breeze comes by and they feel, you know, the wind go across their neck. Normally that wouldn't cause pain, but in allodynia, they would experience pain. Hyperalgesia is caused typically because of damage to the nerve endings, and this is just a hypersensitivity to that painful stimuli. Sensory homunculus. So I learned from Noel that homunculus, by definition, actually means that it is a malformed person, and you'll see in a few slides why that is. So the sensory homunculus is a topographical map in your brain of the entire body. It's like the virtual body in your brain. It's located in your postcentral gyrus, and the more sensitive the region of the body, the larger its representation. For example, you'll see in the next image that the hands, feet, and lips are super large in representation in the brain, in that virtual body in our brain, because they are more sensitive. Obviously, for survival purposes, right, we want to have that dexterity in our hand. We want to be able to sense if something's hot, if we're touching, and then also our mouth with eating and all of that stuff. So here is the sensory homunculus. It is, this is what our body virtually is like inside of our brain already. So this is normal. So just take that in for a moment, that this is a normal representation of our body and our brain. Now, what can happen in a prolonged or persistent pain experience is that because of that central sensitization that may have occurred, meaning the prolonged pain state, the whatever the cause, one of the body parts could become larger. So for example, if someone has a foot and ankle injury, and based on one of the influencers of that biopsychosocial model, if it's biological, psychological, sociological, that is causing the pain experience to persist, the foot will actually become larger over time. Now, I also want to say, because I didn't yet touch on it, that no matter what the stronger influencer is of the pain experience that that person is experiencing is still real. So if it is biological, that is a real pain experience. For example, if they fractured their ankle, and that is one of the dominant influencers of that pain experience, their pain is real. If they didn't fracture their ankle and they're having foot and ankle pain, and the primary influencer is something psychological, sociological, maybe an emotional trauma, their pain is still real. We know this personally from experiences. For example, if someone near and dear to you passed away and you have you're like bent over in stomach pain because of the grief, of course that pain is real that that person's feeling. It's strongly influenced by their psychological experience. Going along with that, as a pelvic floor physical therapist, I treat many people who have experienced sexual trauma, and honestly, any kind of trauma, there is that huge psychological, sociological aspect of it. And it doesn't discount the fact that the pain that they're coming in for is not real. It is real, regardless of the main influencer. Just want to put that out there. So here's another breakdown of our sensory homunculus. So you saw it in human form, and then you can see over here how it looks if you were to cut through the cortex of the brain. So you can see the face, the lips, the hands, and then the other body parts are represented much smaller. I can also show you over here on the right, this is the motor homunculus, but less important for us in what we're discussing. Sensory homunculus has more to do with the pain experience. So phantom limb pain, I thought this was a great example to bring up because, again, this is real pain that they're experiencing. The representation of the limb in the sensory homunculus is still present despite the amputation that occurred in whatever limb it was involved. The virtual representation of the body is still present in the brain. However, smudging can occur in which there is no longer a clear boundary representing that limb. This can be reversed in therapy, and thanks to neuroplasticity, which is what we're going to be getting into next, you can change that virtual representation of the body in the brain. So this is the positive and hopeful aspect of managing pain, that neuroplasticity and that plastic nature of our brain allows for the changes of the representation of the body to take place. So neuroplasticity, pretty straightforward. Brain has the ability to change pathways and rewire brain signals. The homunculus itself, that deformed person, it's always changing, and we can influence the change through utilizing the biopsychosocial model for pain treatment. You have to address all three factors that may be experiencing, or that may be, that should say, causing the pain. Thoughts and beliefs are nerve impulses. So just as if someone were to get bit by a snake, that would generate a nerve impulse, thoughts and beliefs do the same. There's a chemical change that's happening, and I am no neuroscientist. This is all from my training in graduate school, which we did study neuroscience. But what Lorimer Moseley and David Butler discuss is that the brain has the final call for deciding if something is dangerous for the body tissue. They talk about thought viruses that are often common in people who don't understand the biology of pain. An example of a thought virus is, I'm in pain, so there must be something harmful happening to my body. One thing that I speak about with my patients who are in more of a persistent, quote unquote, chronic pain state or intermittent, episodic, whatever it is to change and challenge that internal dialogue and that response to the painful experience by reminding themselves that I am not in danger. I'm feeling the pain right now, but I know that I'm not in danger. Now, there are tons of other things that can help with this: meditation, mindfulness, cognitive behavioral therapy, psychologist, psychotherapy sessions are very important in managing pain. So if I have a patient who isn't already seeing a therapist, I will typically recommend that they start, because I cannot be the only one assisting with this. I need them to go to a specialist who knows how to help guide someone through the complex matrix that is our mind. I wanted to just finish up with an example of what the NOI group lists as danger in me and safety in me. And so they broke it down into 7 categories. You can see they're color-coded, things you hear, see, smell, taste, things you do, things you say, things you think and believe, places you go, people in your life, things happening in your body. And how one side represents danger and thoughts that would provoke that painful experience, and then safety in me, which would provoke that parasympathetic response, which is calming, relaxing, and will help to reduce the pain and allow for healing and allow for those neuroplastic changes to occur. So things you hear, see, smell, taste, touch, danger in me, looking at an x-ray, sounds at the dentist. Now this is all contextual, you know, the context of this is very subjective. So this is for just an example. Looking at an x-ray may not provoke danger in someone else, but for this example, they're saying it does. Versus safety in me, hearing that my scan is all clear, gentle massage. I'm going to go down to things you say. Danger in me. It's just old age. I've got fibromyalgia. Versus safety in me, there is a light at the end of the tunnel. I understand what's happening. I'm going to just jump to the bottom. Things happening in your body. Depressed, anxious, acute inflammation would be danger in me. And then over here in safety in me, happy, optimistic, and acute inflammation. So they listed this twice because it depends on the context, depends on the person's understanding of the biology of pain. And you can see some of the other examples there. So some key pain science points. This is just an introduction. This lecture and this topic can be detailed for weeks. You know, there's tons of books on pain science, but for patients and clients, key points is how you think about your pain can change the way it feels. Understanding pain is important because it changes the way you respond to pain. Remember, understanding that you're not in danger to help modify that neuroplastic or encourage neuroplastic changes in your body is important. Retraining the pain system may mean testing yourself physically, moving more than you normally would, and being honest about your current attitude and beliefs. Knowing when to consult a professional, such as a pain management MD, psychologist, PT, neurologist, etc. Some other key points. This is mainly for professionals. If a patient or client's pain worsens, a new injury occurs, patient expresses suicidal thoughts, or there's no improvement, obviously there's some follow-up that is required to get that patient moving along. It's also important for healthcare professionals and movement practitioners to be very wise with their word choice, because this affects the patient-client psychological state and the movement experience. So that's touching on neuro-linguistic psychology, which is kind of debated in the healthcare world, but I'm just saying from personal experience, I have seen the difference in patients depending on how myself or my colleagues word things and the manner and energy in which it's expressed. So I'm going to stop the screen share and just take a few minutes to see if you guys have any questions. Okay. All right, no questions? All right.
I have a question, Melanie.
Yes.
If there is a biological underpinning of what's going on, can you change the level of pain that's experienced using the other 3 aspects, or do you have to change that biological underpinning before the pain levels change?
So changing the psychological and sociological will absolutely help, despite there being biological influencers present. However, there may be a limit.
Okay.
Mhm.
And then
Any
is
other
the
questions?
converse
Yeah.
true? Like if
And
you then address the biological underpinning, um, will you? It seems that you can still experience pain if you don't address the other two aspects, right?
absolutely. Yeah, that's what's seen, that's seen very commonly. Any other questions? Okay, so I'm just gonna wrap up with, Noel, did you have a question or no?
I, I was just wondering about smudging.
Ah,
If you could, I don't know. I was wondering if you just return to it for a moment,
yeah,
if you had time, just to explain it a bit more. Um,
huh. Well, if I could, hold on, let me change, whoop, whoop, there we go, okay, now it's working. Smudging, okay. So smudging, if you think of that homunculus being drawn with a pencil, okay?
okay.
And then think of someone taking an eraser and just like not completely erasing it, but just like starting to erase the edges of one of the limbs, maybe the hand, so that it kind of becomes blurry, and the boundary and the border of that limb represented in the brain is it's not clearly defined.
Okay.
This commonly happens in phantom limb pain, which is why I mentioned it during it, but it can be reversed.
Is there a way that the brain determines what the boundary is between one's body and everything else outside it?
So the interesting thing about the brain is that even if you were to close your eyes and, say reach for something, your body will still know where your brain, I'm sorry, will still know where your body is in space, right? And will know what limb is moving. But can you rephrase that question again? You're saying, is there a way to?
I guess another way to say it is how do you know where the body starts and stops?
So when we are born, we have a virtual body already imprinted in our mind in that postcentral gyrus in the sensory homunculus. So it's already built in.
Yeah.
Yeah, and actually, that could be discussed even further, because phantom limb pain, some individuals are actually born without limbs, right? And there's
Right.
been some research that's shown that they still experience the sensation of the limb being there, even if they never had the limb. So it's complex, but all I can say is that when you're born with this virtual setup, a virtual map of the body in your brain already.
Is there like a scholarly article or something like that about phantom limb
Oh,
pain?
there's tons. Yeah, I could share some with you. There's tons.
I'd appreciate that. That would be great.
Of course.
Yeah, thank you.
You got it. So I'm going to go back to the screen share, actually, because I just want to finish up by making sure everybody knows the rest of the calendar for, there we go. Okay. So Healthy at Home, this is going to be happening every first and third Friday of each month. I request that we have 6 people signed up for me to run it. So if you know any friends or family members who would benefit from a free lecture, just have them contact us. I'm running a Tuesday 11 a.m. class, but that's full. I have a team now, and one of my colleagues is running an intermediate level class Wednesdays at 6 p.m. There are a few spots left in that, and then PT sessions are continuing. Healthy at Home schedule for the rest of this month, I'm going to be speaking about fall prevention on June 19th. So if you are interested in learning about the science of our balance and how to prevent falls, Sign up and I'll see you then. And then July 3rd, osteoporosis, and July 17th, pelvic floor dysfunction. Further dates to be disclosed later. Some of you have been tuning in for my live stream series. I still have a few more guests, so this takes place on Instagram and or Facebook, YouTube, depending on the guest. This Tuesday, I'll be on Instagram talking about fascia with Tracy Matthews, who's a Pilates master here in Brooklyn. And then Wednesday, I'll be chatting with Dr. Ben Taylor, who's an osteopath here in Brooklyn, about osteopathic tips on how to stay healthy at home. His live stream that I'll be leading will be on Inspira PT and Pilates YouTube channel and also on our Facebook page. So if you have any questions, just shoot us an email, give us a call. That's our contact info. Thank you guys so much for participating and signing up. And then here's some resources. Explain Pain is the main book that I was referencing, as well as the Neuro Orthopedic Institute. And Noel, I will follow up with you with some research articles.
Thank you very much.
Okay, guys, stay safe, and I'll hopefully see you next time.
Bye. Thank you.
Bye. Thanks, Melanie.
Bye.